Hi, everyone. My name is Tino, and I'm from the DSI Africa Coordinating Center. We'll just wait 1 or 2 minutes for people to join, and then we'll get started. All right, I think we can get started. Feel free to introduce yourself in the chat, and we'll begin with the Palladium Group. So Palladium is an international development organization that works extensively in deploying machine learning solutions for health and climate change. And presenting for the Palladium Group is Anubhuti Mishra. Anubhuti, please, over to you.
Yeah, hi. Thank you. I was curious, I have a slide deck. Should I share my screen or will it be
Yes,
shown from
share your screen?
Okay, just 1 second. Can you see my screen?
Yes, I can see.
Okay, great. Thank you so much for this opportunity to share a little bit about Palladium. I'm Anubhuti Mishra. I'm a senior technical advisor for data science at Palladium. And I'm based out of Washington, DC, and I've been working with Palladium for almost 2 years now. I'll give you a brief overview of Palladium. So Palladium as an organization works across over 90 countries across several different sectors, from global health to education to environment to government and impact measurements, climate. We work across almost all sectors, and we are headquartered in Australia, but we work in Asia, Africa, Europe, and the Americas. So data science at Palladium currently covers 3 different areas. Our first one is public health, where we have done a lot of projects with USAID and CDC and several other partners on helping countries use machine learning based algorithms to identify patients for HIV with high risk of HIV, being HIV positive, or predicting patients with high risk of dropping off their HIV treatment. We have also deployed multiple anomaly detection algorithms for automated data quality assessment across Africa and Latin America. We also work in supply chain, where we build algorithms for forecasting of health commodities, route optimization, or figuring out the most optimized way to allocate either vaccines or health resources within a country, from national level depots all the way down to healthcare facilities. And our third area is climate change, where we conduct a lot of situational analysis. We do cost efficiency analysis. We also do a lot of climate modeling. So we will work with lots of open source remote sensing data combined with our proprietary data to build models to predict either likelihood of floods or how it might impact agriculture in a particular area. So that's the type of work we do at Palladium. I'll now dive deeper into each of these areas a little bit. So apologies, I think this, I don't know how to hide this, but sorry. So in healthcare, we built a lot of clinical decision support tools where the one on the left shows you how we have deployed a machine learning model for HIV testing optimization. So here you can see what we do is we take patient data along with some contextual data about the healthcare facilities, about the areas they live in, and then we've built a classification machine learning model. Using that, when patients come in, the ML model would assess them for their risk of HIV infection, and then generates certain risk score for each of these patients. Based on these risk score, these patients could be, the healthcare worker can choose to test maybe the top 20%, top 30% of all of these new patients who've come in. Then on the right-hand side, we show anomaly detection, how anomaly detection can be deployed, can be used for just HIV patient line data, line listing data. And what this tool does, it looks at the correlation between different variables and then uses that to predict other values. And if any existing value differs extremely or significantly from this predicted value, that is marked as an anomaly, so that it can be, this type of algorithm can be used for automated data collection. Since we have 5 minutes, please get back in touch with me if you're interested in knowing more about any of this work, but I'll just rush through this. Then we've developed several algorithms and dashboards for logistics and supply chain management, particularly when it comes to HIV and TB commodities. And it goes from predicting, forecasting what the future needs for certain types of commodities, identifying the best route for transporting commodities from one depot to districts to healthcare centers, and also identifying the best way to allocate certain health commodities or vaccines based on supply and demand constraints. So this is an example of a dashboard we developed in R Shiny for one of our programs. Then for climate change, we have recently started a couple of projects. One looking at the nexus of how climate change and health, so trying to understand how climate change might affect healthcare programs, or would change the dynamics of the demands from people, or how excuse me, how healthcare services are rolled out excuse me, in a country. So one of our projects is looking at sorry, effects of climate change on sorry, I couldn't hear you clearly. Yeah, this is the last slide. I think my time is almost up. So yeah, we're looking at effects of climate change on how we should change how our community healthcare programs are funded, what might be, how our demands on the public healthcare system might change in the future. So that's Palladium.
Hi, Davis, which room would you want
Thank
to join?
you, Ruti. Just as a reminder, we will have all the presentations first, and then we'll have a Q&A session at the end. So thank you for that presentation. Next up, we will have Palindrome Data. Palindrome Data is a South African for-profit organization with a desire to apply private sector data science innovations to the public health sector. And presenting for Palindrome Data is Amira Salduka. Amira, please take the stage.
Thank you, Tino. Hi, everyone. Looking forward to today's presentation. Let me just share my screen with all of you. My name again is Amira Salduka. If you didn't catch that, I'm with Palindrome Data as the Partnership Development Manager. And like Tino has mentioned, we are a South African team of data scientists, program analysts that are really passionate about improving healthcare and working with implementing partners to optimize the programs, the wonderful health programs that they're already rolling out, looking at how we can make it more efficient, what factors affect scale, how do we drive patient outcomes through the data that they're already collecting and gathering the right insights for the users with that data. And we believe that this can be done by understanding patient needs better so that we can match to build practical predictive tools our partners implement within their programs to drive these efficiencies, targets. Nations are categorized in so that you could better design health interventions or program interventions to meet their needs, increase engagement, satisfaction, and better outcomes. Traditionally, archetypes and population segmentation is not new in health programs, but they are largely driven by gender and age segregations. And what these large segregations do is they miss opportunities to identify specific individuals within that group that may need more support to those that need less support. For example, within HIV and looking at interruption in treatment or previously lost to follow-up, the adult male group is considered a high-risk group for dropping out of care. But if you look deeper within this group at the various behavioral characteristics of who they are, their visit patterns at the facilities, you can see that there are some groups that are very committed to their treatment journey and will come to the facility to pick up their meds, will come to their appointments. There are others, though, that may struggle and need extra support because they may work on weekdays and are unable to make their appointments during the week, or they have fear of stigma and tend to hop around facilities, or even because of work, tend to pop up at different facilities or drop out of care for long periods of time. And so may need different interventions or support to ensure that they reach their treatment goals and are able to remain virally suppressed and stay on treatment. And so we use their behavioral characteristics and visit patterns to drive these deeper profiling so that programs can look at designing interventions that better match these patient needs, try to understand what drives their health-seeking behavior, look at increasing patient engagement through the health worker and guiding them in understanding which areas to dive deeper into with the patient during consultation. We also develop predictive models, which is one of our core offerings. And the two large predictive models that we've developed, validated, and tested in both South Africa and Nigeria is around viral load and interruptions in treatment. And what these predictive models do is give you oversight and understanding of what your population risk is within your program or within your facility, and then help you plan on how to allocate resources towards addressing those that need intensive support versus those that need much lighter support. In this way, you can look at how your resources may need to change over time in treatment for patients, and where you can create efficiencies around which services and resources to deploy to address your patient risk populations. And this has been used largely when looking at monitoring prognosis, or if a disease is going to have a person is going to have an adverse outcome, looking at the likelihood of having a disease or contracting a disease, reducing costs, clinical decision support for facility managers, resource management across that facility, and personalizing treatment plans based on risk patterns in your population. Our third offering is around making those predictive models more practical to the last mile and healthcare workers on the ground who are busy with these patient consultations, and giving them insights immediately that can help them increase their engagement, understand their patient better. And so we've converted these algorithms, predictive algorithms, into simple triage tools that healthcare workers run through during their consultation, asking a few questions that come from the patient file, a few psychosocial questions about their lifestyle and behaviors, to get a sense of what kind of support does this patient or client need. Do they need light support? Do they need intensive support? And help guide their consultation, help prioritize the time they need to spend. These tools are available on both paper and digital platforms. And really, they are a way to operationalize data science innovations, look at giving real-time insights to health workers on the ground to make decisions faster, to feel confident in their decisions, to engage with the patient, and shift from reactive health services to proactive services. Mostly our data science innovations are geared towards that shifting from a reactive state to a proactive state by identifying early triggers for program enrollment for support, distinguishing patient needs by looking at their behavior and psychosocial characteristics, and helping health workers prioritize their time with clients and offer personalized services based on their needs. We've piloted and validated these tools in both South Africa as well as Nigeria. And we have worked with a bunch of implementing partners to roll this out over the last 3 years. And we're looking to connect with more partners across African countries, as well as South Africa and Nigeria, to understand and contextualize these tools for operationalizing and scaling them across the country. Thank you very much.
All right, thank you, Amira, for that presentation. As a reminder, once again, we will take questions at the end. So next up, we have Cognitive Care. Cognitive Care is a healthcare AI startup and pioneer in maternal and infant health. And presenting for Cognitive Care will be Sheena Gill, as well as Dr. Manoj Taltumbade. Please take the stage. Thank you.
Thank you so much. And I want to thank both of the companies who went before us for the great work that they are pioneering in as well. And I want to thank DSI Africa for this opportunity. We are very grateful to be here. So hello, I'm Sheena Gill, President and CEO of Cognitive Care. And I'm joined by my colleague, Dr. Manoj, Head of Research. So at Cognitive Care, we are a global organization seeking to improve maternal, infant, and child U5 outcomes with AI and ML models and insights to support community healthcare workers to hyper-personalized care and get resources to those who need it most. We work in Asia, Africa, and in the United States. Our problem statement is quite clear. I mean, if you could just look at this data, it's appalling. And frankly speaking, mothers, babies, families, and communities deserve better. In the lifetime risk of an African woman, she could potentially die at a rate of 1 to 39. And compare that with Europe, where it's 1 in 3,300. The CDC itself says 4 out of 5 pregnancy-related deaths are preventable. And in sub-Saharan Africa, 92.3% of pregnant women do not attain the recommendation of at least 8 ANC contacts. Look at postpartum hemorrhage. It's a leading cause of maternal deaths, representing 30 to 50% of maternal deaths in sub-Saharan Africa. And most PPH-related deaths are preventable with timely detection and initiation of care. So who exactly are we? Cognitive Care is a team of global physicians, data scientists, engineers, computational biologists, public and population health experts. Core to our mission is the belief that digitally enabled health services powered by deep science applications can help to close those care gaps. And our team is particularly passionate about maternal, infant, and child health. As a mother who has lost 4 pregnancies myself, this is very personal to me. We have a platform and solution called MAHIC, Maternal and Infant Health Insights and Cognitive Intelligence, which can ingest clinical and social determinants data, merging data from multiple data sets to create a 360-degree view of patients to quantify and triage for outcomes important to the specific populations longitudinally. We can do this at both the individual and population levels and empower our insights with explainable AI. The number of patients or provider touch points that can incorporate AI are growing every day. And thus you can see how our insights are used in collaboration with multiple outlets to make impact. The outputs improve operational efficiencies, triage to get resources to those who need it most, all while improving access and quality. Furthermore, our insights are used in a variety of ways. They can be used with RPM, with telehealth, directly into EHRs with patient engagement for purposes of training, cohort development based on risk profiles as seen on the right side of this chart. But critically to this conversation, they can be used to feed on-the-ground systems that empower community healthcare workers and patients to address last-mile issues and adherence in culturally and language-appropriate ways. We believe the path to impact is not one that you traverse alone, which is why we are proud to partner with many organizations, a few of which you see here. Just some examples of our work. We are currently working with the LV Prasad Eye Institute, which works in Africa as well, on triaging for retinopathy of prematurity, which is linked to preterm birth, and predicting propensity for myopia early, all in low resource settings. And in fact, we're also working with them on developing training curriculum to ensure sustainability beyond our work. Our work funded by the Gates Foundation in the antenatal research collaborative sites, including Kisumu County, achieved metrics above 90% accuracy for identifying outcomes such as postpartum hemorrhage. And Dr. Manoj will talk to you about that in just a second. This work is really taking off. In fact, we've now partnered with Kenya Swap and Kisumu County and Elara Health, which many of you may have heard of, in prospective validations and implementing our models in 25 clinics, once again, to ensure sustainability. On the left, you'll see some of our the patients that are involved with the LV Prasad Eye Institute programs. And on the right, we're proud to display a picture of our team in Kisumu County. That's Dr. Dickens Anyango right there, who actually happens to be a Fogarty alumni as well. Further, given the significant success of our AI models, we have also been asked by some of our partners to help upstream with data surveillance design and data quality evaluation, thoroughness, mitigation of bias, et cetera, and training once again, curriculum development, and other evaluation for projects so that future projects beyond us can have the same success we achieve. It's all about sustainable impact. We have also done or are currently performing cutting edge work with sepsis, preterm birth, preventable C-sections, microbiome, social determinants of health-related insecurities, low birth weight, and many other areas. I'll turn it over to Dr. Manoj right now for the rest of the presentation.
So thank you, Sheena. So this, I just want to give you the glimpse of the work that we have done with the Kisumu County Department of Health and the Kenya Antenatal Care Research Center. So in this, we worked with the Kisumu County to analyze the data of maternal visit data for around 2,500 women. And as you can see, though usually the pregnancy data, although it's a specific time period, but the data is asynchronous. Not all mother will have the same data collected at the same time point. So we use the data pipeline system to convert the data into structured format so that it can be machine trainable. And in our work, we developed multiple machine learning model to identify and predict the risk of postpartum hemorrhage. And in those, as Sheena already mentioned, our one of the model naive base perform significantly well than the other model. And as you can see on the right hand side that with the model that we have developed in the Kisumu County, we can identify more than 75% of PPH cases only by screening the high risk 30% population that were detected by our model. And as a part of our AI platform, we also have a explainable AI module where you can see for this current population, we have seen that the factors such as anemia, limited prenatal care, and high blood pressure and respiratory rate during the intrapartum were mostly associated with the PPH outcome. So with that, I would like to thank the organizer, and we are available for any questions if you have. Thank you.
All right, thank you, Cognitive Care, for that presentation. So that brings us to the end of the presentation session, and we'll now take questions. So please feel free to raise your hand, and I'll acknowledge you, and then you can ask your question to any of the presenters. So I see Dr. Connect's hand is up. Please ask your question.
Good afternoon. My name is Dr. Joseph Olowe. I just like to see the first slide, the data. There's a bunch of data on the first slide. I missed that. Or are you going to share the presentation after the conference?
Maybe before they answer, all the slides and presentations are available on the DSI Africa website. I'll just paste a link to that page on our website. Does that answer your question? Or
yes, and one more thing. Are they only working in Africa? Because I see the data from Kenya. Are they only working in Africa or other part of Africa? Are they only working in Kenya or other part of Africa, or are they working in the US as well?
We actually started our journey in Africa, and we are primarily working in Kenya right now, and we're absolutely interested in expanding our work to make more impact in Africa. And yes, we also do work in the United States.
Thank you so much.
Can I speak? Hello, can I speak?
I can hear you. Go ahead.
Okay, yeah. I'm Dr. Angela Makolo. I'm the PI of University of Ibadan Bioinformatics Group Node of Atria Bionex. The presentations have been wonderful because I'm actually I'm a bioinformatics expert, but my background is computer science. These presentations on applying AI in health is important. I found it, I could identify with it greatly. So I want to know the collaborative efforts that you have. Do you have any collaboration with Nigerians? Because we have, in my research group, I have students that are very skilled in AI, machine learning and all that. And we're trying to assess data. Working with data has been a challenge. You know, what we have is online data, and those data, we don't have a reflection of what really happens. You know, we don't have access to data. So I want to know what opportunity we have. If this DS Africa opportunity will give us an opportunity to collaborate with people, with scientists who already have this data available for us to use our machine learning tools to work on, to mine, get more information that will can collaborate. Are there opportunity for such collaborations? I don't know if you get my question. Maybe I have spoken a bit, I was a bit too fast. Did you get the question?
I'm sorry, was that question for cognitive care? Could you repeat again? I'm sorry.
Okay, so I'm trying to say that I said that I'm from Nigeria. I'm a bioinformatics expert, and we are in my research group, we are computer scientists. So we collaborate with biologists. But the problem we have in the group is assessing data that are relevant, especially to African research. So I want to know if your group, I came a bit late for this presentation, I was in another breakout session. So if you have these data sets, how this collaboration can give rise to having access to data sets that we can use machine learning tools to work on?
Oh, yes, we would love to chat with you about that. We're absolutely interested in expanding our work, and we do have significant upstream, tasks that we've done that involve data quality, the thoroughness of the data, ensuring that it's ready for usage. Dr. Shah, or excuse me, Dr. Manoj, I don't know if you want to add to that, but yes, absolutely, we'd love to chat with you, Angela. I think that's a very good point you raised, and we're happy to discuss this further.
Okay, good. Okay, good. Thank you very much. We would like to have to discuss it further. I'm really interested in discussing it further. Thank you.
Thank you, Angela. Tawarai Chikoti, do you have a question?
Hi, Tino. Yeah, thanks. I think this is for Palladium and the other lady. Basically, it's mostly related to the HIV data analysis stuff of things. What I wanted to know from Palladium is their ML models, are they basically, is it like a pilot thing, especially for South Africa, because I'm working on HIV data. And also in terms of the data source, are they using the old tier, the same tier system they're using for data extraction, or they possibly have got another tool that they're using to get all that data? Just because of the data quality issues also, I would want to know how much of it has it affected in terms of their data, of their ML models in terms of analysis. I think this goes the same way to the other company that is working on HIV data. Thanks.
Okay, sorry.
Will someone take that?
Sorry, I heard Palladium.
Yes.
Did you have specific questions for us, or?
Yeah, I just wanted to know your within your ML models that you have worked on for HIV testing. Have you been? Is it in South Africa, or you have been using it from different countries? As I'm working on the data set in South Africa using TIA, but I understand there are data quality issues also. So I wanted to know how much of it has affected your ML models, and also at what stage is this going to be adopted within the USAID PEPFAR report in terms of predictive analysis?
Yeah, okay. Yeah, so we have, we are working on this model currently in Nigeria. We have deployed it in Kenya, where we are working with CDC, and this model has been deployed and is operational across several HIV testing facilities. So in our case, I mean, there are always data quality issues, but we were lucky to be working with CDC at a point where EMRs had already been deployed. So the quality of the data was fairly high. And then, of course, there are always data entry issues, and in those cases, we work with the data. We see what can be included, what can be fixed, what should be excluded. But yeah, in all our projects, we've been working with either USAID deployed USAID facilities that have EMRs, or CDC facilities that have EMRs. In South Africa, we've done a lot of data quality assessment, the automated data quality assessment. Patient data deduplication as well.
Thanks.
Yeah. But I'm happy to answer questions in more detail. Please feel free to email me. I'll put my email in the chat.
Sure. All right. Thanks.
Thank you, Flavius. Flavius Nkubli, please ask your question. You are muted if you're trying to speak.
Hi, everyone.
Hi.
I'm sorry I was muted, and I joined the meeting late. My question is similar to that of the previous person who asked the question on possible areas of collaboration. I am Flavius Nkupli from University of Maiduguri Teaching Hospital. And we are data rich actually, but how do we really maximize the opportunity we have with data in radiology particularly? That's an area I want some of the speakers to throw more light on. I wasn't opportune to really listen to all the speakers. Thank you.
All right, would any of the presenters like to take that one?
Hello, did you get my question?
I can
Yes,
speak
yes.
to that for a second. So I mean, we don't work with radiology data particularly, but like our approach to building or starting any data science project is always starting with the questions. What are the questions we are interested in? You know, of course, it's very important to have the data, but having that clear idea of what do we want to use machine learning or AI or data science for, and having that clarity sort of guides your entire work then. And in case you feel like you have the data, but you don't have the technical capabilities or the knowledge, I would suggest reaching out to one of us or the larger group to see who can help you out with building such models.
Okay. Thank you so much for that insight.
Thank you, Flavius. We're running out of time. Maybe we can take one or two more. Martina. Martina, you're muted.
Can you hear me okay?
Yes.
Yeah, so I think my question was answered. I thank you all so much for the phenomenal presentations. Cognitive Care, I just absolutely love the AI modeling that you use and just thought that they would be incredibly generalizable to other conditions. We do a lot of work in traumatic brain injury. So I was just curious to know if there's opportunities to collaborate in that sphere, using the same technologies, of course, but trying to basically identify patients at high risk, you know, high risk for adverse outcomes, not necessarily mortality, but perhaps disability, and medium risk and low risk. So if there is a way to do that, that would be phenomenal. I'm an assistant professor of medicine and public health at the University of Pittsburgh, originally from Ghana. So I would love to talk some more.
Absolutely. Thank you for your comment, Martina. And yes, actually, we do work, our core is maternal, infant, and child health. And oftentimes what we find is we're working on things like sepsis, neonatal sepsis, maternal sepsis, but then it's generalizable to other things as well. In fact, the Henry Jackson Foundation, which serves the veteran population, contacted us for very similar things. And be happy to chat with you about that offline. But yes, absolutely, we would be interested.
Hello, just a second. Shona, how do we get your contact so that we can continue chatting offline about this collaboration?
Sure, certainly. I put my email in the chat. It's sgill at cognitivecare.com.
Okay, please. I didn't get it. Can you just put it again so that we can contact you?
Sure.
I didn't say it. Okay.
I'll put it again.
Okay, please do.
Yeah, it's my name, my first initial S, last name GILL at cognitivecare.com.
S-Gill. I can't see. Okay, S-Gill, yes, I've seen it.
At cognitivecare.com.
S-Gill at cognitivecare.com. Okay.
All right, we are basically out of time, and I think the room will close any second now. But Oli, if you have a question, can you try to squeeze it in? Oli, are you there? Okay.
Yeah, can you hear me?
Yeah, I can hear you.
Perfect. Thanks for the opportunity. So my name is Bolo. a data programmer at the Children's Hospital of Philadelphia in the US here. And I think my question is pertains to access to data, especially in Nigeria. I think one of the challenges we've seen for some of the projects that we're trying to do in Nigeria is we don't really have access to like healthcare data, EHR data and stuff like that. I was wondering if we have anyone on the call who's facing similar issues and is looking to collaborate. Thank you.
Thank you for that question. Any of the presenters want to take that? In 40 seconds.
I can maybe help with that. Palindrome Data doesn't specifically have any data or own data of their own, but we do work with local NGO implementing partners and programs. So you can connect with us and we could try and connect you to our partner network as well, who are mostly custodians of data.
Thank you.
All right, thank you. You will all be returning back to the main room now, and we will start the next networking round soon. Thank you, everyone. Bye.